In this episode of the Nurse Practitioner Podcast, Dr. Lauren Pfieffer discusses the assessment and treatment of dizziness and vertigo. Your article explains that dizziness is a common symptom in primary care, but dizziness has several classifications and can be quite confusing. Can you expand on those?
Dizziness is a common symptom of patients in primary care. Dizziness is a subjective complaint of patients that can mean many different things. You are right, it can be quite confusing to look at the literature regarding dizziness because there are various concepts and classifications used, which make it really confusing. The categories used most often are vertigo, disequilibrium, pre-syncope or syncope, lightheadedness, and non-specific dizziness. There's a differential list in our article that helps break down common diagnoses for these 5 classifications. Vertigo is what we're going to talk most about today, as it's the most frequent cause of dizziness. Patients in literature describe vertigo as the feeling of motion when still. I've had some patients talk to me about how it feels like the room is spinning, and that's related to the vestibular system dysfunction. Vertigo and dizziness are often used synonymously, but they really shouldn't be. Vertigo is a differential of the broad symptom of dizziness. Disequilibrium is the awareness of insecurity, imbalance, or unsteadiness when walking. Presyncope or syncope is related to the feeling of about to faint or actually fainting. It's an important classification and can be linked to more serious abnormalities such as cerebral hyperperfusion or cardiac abnormalities. Lightheadedness is a term that we as healthcare providers hear often, and it's often associated with patients feeling kind of woozy or faint-like. Its similarity to the term presyncope makes the differentiation between the two quite complicated, and so that term isn't used as much. But I do have patients come in all the time with the chief complaint of lightheadedness. Lastly, non-specific dizziness classification kind of clumps them all together. Those patients that are difficult to find a specific physical or diagnostic finding to support any of the other diagnoses. So some diagnoses that are seen with nonspecific dizziness are psychogenic disorders, so anxiety, depression, also medication-induced dizziness and or hyperventilation. Thinking about medications that can be used to cause dizziness, there are a ton. And so getting a good medication reconciliation at the forefront of this patient visit is really important. Some of those meds that can cause dizziness, so anti-epileptics, antihypertensives, antibiotics, some diabetic medications, sedatives, of course, psychotropic drugs, corticosteroids, aspirin, and diuretics. Those all can cause dizziness.
What is the epidemiology of dizziness?
Dizziness affects about 15 to 20% of adults every year. Vestibular vertigo is the biggest culprit of dizziness, and it makes up about 25% of dizziness complaints. Dizziness and the complaint of imbalance increases with age. Dizziness appears in about 2 to 3 times more frequently in women. There's a lot of risk factor research going on right now about the association of vertigo and migraines, and I really see that being a continuation of research coming down the pike. So I feel like we're going to see a lot more about some risk related to dizziness in the future.
What components of the history are important for dizziness?
The differential list for dizziness is quite long and can be overwhelming for the seasoned or novice nurse practitioner. One of the most important things with this patient presentation is ruling out the red flags. So thinking about brainstem involvement, maybe a stroke, any kind of trauma, that's a really important thing to think about when a patient presents with dizziness. The history for a patient with dizziness is also important. It can expose the diagnosis 75% of the time. Asking the patient to describe their dizziness is the first step in history. There's an acronym that's being used kind of frequently right now, and it's the TITRATE acronym, and it's helpful to gaining key history components and gaining a probable etiology of dizziness. And the acronym includes timing of the symptom, triggers that provoke the symptom, and a targeted examination. Timing can relate to the seconds, hours, days, or weeks that the dizziness has occurred. NP should ask patients if the dizziness is elicited with movement of the head or changing positions, as movement can be a common trigger. Other symptoms that seem arbitrary can really aid in a diagnosis as well. So if a patient presents with dizziness with any kind of visual aura or photophobia, That can lead you to think about vestibular migraines. If a patient is unstable and having nausea with vertigo symptoms, then you need to think about more central causes to the dizziness.
Let's focus on vertigo a little bit, as it's the most common cause for dizziness. Can you discuss the types of vertigo and how you differentiate?
Vertigo can be central or peripheral. Thankfully, the less severe but still aggravating peripheral vertigo is the most common and is seen about 90% of the time. Central causes of vertigo are brain lesions, MS, vestibular migraine, stroke, and central nervous system infections. Peripheral causes of vertigo that I want to discuss a little bit more are benign paroxysmal positional vertigo, or BPPV, vestibular neuritis, Meniere's disease, and vestibular migraines. BPPV is the most common cause of vertigo. It is caused by change in the inner ear within the canalisis system of the semicircular ear canal. This causes loose crystals in the ear, and with movement, those crystals move and make the patient experience vertigo. The timing of this can be short, but it also can happen in clusters. Vestibular neuritis is common as well. It's related to inflammation of the 8th cranial nerve. The most likely culprit of this is a viral infection. Dizziness timing here can be more lengthy, lasting days to weeks, and can be never ceasing, which can cause nausea and vomiting. Meniere's disease is the third most common type of vertigo, and I've been seeing a lot of this in primary care lately, but it's related to increased fluid in the inner ear, and that's what is responsible for the diagnosis. Vertigo and tinnitus are seen with these patients, but they also generally present with unilateral hearing loss. Dizziness is not caused by movement with Meniere's, which I think is a good differentiation among the others. Vestibular migraine is the last one, and unlike the other causes of vertigo mentioned, vestibular migraines has a central cause. Patients need to have vertigo with coinciding migraine to be diagnosed with this condition. There are really specific diagnostic criteria that a patient has to meet in order to be diagnosed with vestibular migraine, and you can see those specifics in our article.
A physical exam for someone experiencing vertigo seems tricky. Can you explain that further?
Sure. Ultimately, we as providers want to rule out these red flags and then work towards an appropriate diagnosis. Assessment is important to confirm history findings and work through a differential list. A HINTS exam, which is head impulse, nystagmus, and test of skew, has shown to be effective at differentiating central causes of vertigo, like an acute stroke, from peripheral causes of dizziness, such as vestibular neuritis or vestibular migraine. Completing an HEENT exam, cardiac exam, and neuro exam are important with patients with dizziness and vertigo. Along with a cardiac exam, I would make sure you're getting orthostatic blood pressures to evaluate for orthostatic hypotension, because that can definitely be causing vertigo. The Dix-Hallpike maneuver can really help to diagnose BPPV, and we put a link to this technique in our article that we hope you find helpful. Proprioception is assessed by gait, bilateral heel-to-shin testing, and tandem walking across the room.
I know you said diagnostic testing is not common with vertigo, but what if you wanted to order labs and/or imaging? What would you do?
Imaging and labs are not very revealing to diagnosis, and often will just add to the ever-growing healthcare costs. Central causes of vertigo warrant labs and imaging to determine the cause, but most often with peripheral vertigo, they are not needed. As a provider, if you're at loss for the exact cause of diagnosis and want to do labs for the patient, there are some labs that you can draw. I would suggest maybe getting a glucose and electrolyte, see if there's anything going on there, doing a thyroid panel, a CBC, maybe drawing creatinine, vitamin B12, and then lastly, kind of keeping the differential of syphilis in your mind, you can do serologic testing for syphilis. Those labs can help reveal issues that may make the diagnosis easier. If a patient has suspected hearing loss with Meniere's, then I would order audiometry. If you suspect cardiovascular issues attributing to the vertigo and dizziness, then I would either refer to cardiology for testing Or depending on your area, you may have resources in your clinic where you can do an EKG, and that's a good thing to do. You can also do Holter monitoring and then carotid Doppler for evaluation. So I'm not sure your resources, but if you have the capability, you can do that, or send to cardiology if that's easier. Neuroimaging is not recommended unless you suspect a lesion. If the patient has unrelenting unilateral hearing loss, then I would do some imaging. Or if you see any abnormal neuro findings, then imaging is warranted. If you thought any of that, so lesion, unilateral hearing loss, or abnormal neuro findings, I would order an MRI.
Is there a general treatment for all vertigo patients, or is it dependent on vertigo presentation?
Treatment is dependent on the cause of vertigo. Vestibular suppressants are generally what is used, and these include antihistamines, benzodiazepines, and anticholinergics. Some antihistamine examples that are used for vertigo are meclizine, Benadryl, and Dramamine. Benzodiazepines, such as lorazepam, diazepam, and clonazepam, can be used but should be prescribed with caution due to the controlled class of the medication. The anticholinergic scopolamine can help with motion intolerance and is quite helpful for those that are having motion sickness. Antiemetics that may alleviate nausea and vomiting are promethazine, Reglan, Compro, and Zofran. BPPV treatment is aimed towards the repositioning of the crystals, which is called the canalith repositioning maneuvers, or the CRP. An example of CRP is the Epley maneuver, which is the most common. This maneuver is really successful. So 70% success rate on the first attempt of doing the maneuver, which I think is a crazy high statistic, and nearly 100% successful on successive maneuvers of doing the Epley. Side effects of doing the Epley maneuver is really patient nausea. So that's what I see the most. I've actually had a patient throw up in the room after I've performed the maneuver, so be really careful with that. Ever since I had that happen, I've had a barf bag close by. Providers need to be cautious or avoid CRP if the patient has this vascular disease, and that's related to the risk of stroke or vascular injury. If the patient has back or spinal conditions, cervical conditions, I'd avoid the Epley or CRP. If the patient has Down syndrome, severe rheumatoid arthritis, obesity, and Paget's disease as well, I would probably avoid CRP in the office. We place links on how to do the Epley maneuver and the Brandt Darth home maneuver in our article. If you feel uncomfortable performing the Epley, then you can send to an ENT or to physical therapy. I have a PT that I work really closely with, and I can usually call them up and have my patients see them same day in their office for treatment of vertigo, which is awesome because patients want the quick relief. And so getting them into PT as quick as you can is great if you don't feel comfortable. Those home maneuvers, the Brandt Darth maneuvers, can be done at home by patients and may prevent the need for a clinic visit. So if the patient has a history of vertigo, so you could give some patient education about doing those maneuvers at home. Meds are not usually successful for BPPV management. If anything is prescribed, it could be a vestibular suppressant to help with the nausea, but that should only be prescribed in addition to performing the CRP maneuvers. Meniere's disease is best treated by providing some lifestyle education for the patient. So recommending low-salt diet, reducing caffeine intake, and limiting alcohol consumption to no more than 1 drink a week can be really helpful for patients with Meniere's. Thiazide diuretics can be helpful for those patients as well to help with that increased fluid in the ear. Vestibular suppressants can be used here as well. An ENT referral is an appropriate thing to do here for Meniere's management in primary care. Vestibular neuritis, so remember that's related to the inflammation of the 8th cranial nerve. And once that virus is gone, the inflammation goes down and symptoms disappear. Giving this patient reassurance that this is self-limiting is really important. If a prescription is needed, I would recommend a vestibular suppressant, but just doing that for a couple days because I'm hopeful that the virus is going to go away, that inflammation is going to go away, and the patient's going to feel a lot better. Vestibular migraine treatment focuses on avoiding migraine triggers. So really doing a thorough migraine history. You look at the migraine diary. How frequent are they having it? What caused that migraine? So sometimes doing migraine prophylactic medication will help decrease those vestibular migraine attacks.
What patient education is most important with dizziness and vertigo patients?
Safety needs to be considered for those that are dizzy or are experiencing vertigo as injury can occur. Make sure you educate patients to move slowly from sitting to standing and from standing to sitting. Any kind of rapid movement is what generally triggers the dizziness and then the chance of injury from falling, especially in older adults. So you need to educate everybody, but spend a lot of time with your older adult population talking to them about safety needs. And then I tell patients not to drive or operate heavy machinery while they're dizzy. That seems kind of a silly thing to even have to suggest to patients because you think that would be common sense, but you definitely need to not only verbally say it, but then document it. More patient education is given dependent on what is causing their dizziness or vertigo. And that's really all I have related to the overview of dizziness and vertigo in primary care. Dizziness can be challenging, a really challenging patient presentation, but methodically narrowing down differentials through the history and physical exam can lead you quickly to a diagnosis and get that patient relief. And that patient getting relief is really our number one goal for care.
This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer.